Hey, it's me, Jen again, and today's guest has the benefit of many years of experience in the endocrinology world. We'll hear more from Dr. Brian Michael of Gettysburg, Pennsylvania, coming up. If you value this content, then please subscribe to this channel because that helps YouTube put this content in front of more people. And that helps more people to learn that they can save their thyroid from surgery through minimally invasive procedures that directly target and shrink thyroid nodules while preserving the thyroid gland itself. Dr. Michael knew of Thyroid RFA long before it made its way to the United States. Once cleared in November of 2018, Dr. Michael was eager to provide this thyroid-preserving technology to his patients. Let's learn more about Dr. Michael and his journey to treating thyroid nodules with RFA. I've heard wonderful things about you from members of our Facebook group.
That's good to hear. I'm glad nobody hates me yet.
And I don't know how familiar you are with our Facebook group.
I certainly know of it. I know several of the people that I've seen who are considering RFA specifically said that they kind of found me through it or found out about the procedure through it. So I think it's a great service.
Thank you. It really came about because I was on this search for an alternative to surgery. Really was just like unearthing a dinosaur, trying to find this information. You know, it was very hard to find information. I was very desperate and I felt like there must be other people out there who want to know this. And so I just felt compelled to share the information. And that was 2 years ago in July of 2019. Since then, it has kind of ballooned, grown to about 2,600 members.
Well, I didn't realize it was so large. That's awesome.
Yeah, I can't believe it either. People are just very excited to know that there are ways they can preserve their thyroid functions. I wanted to take a moment to also tell you, whenever I interview a doctor, I always go to their website and do a little reading about them so I know a little bit more about them. And I just have to say your website has the most thorough explanation I think I've seen on RFA. It is wonderful.
Thank you.
Yeah, it's very thorough information. It's all very easily understood. Good list of FAQs for patients, even for patients who aren't looking to come to Pennsylvania, you know, who are not local to you. It's a really good information source. Good job on that.
Okay. Well, thank you. I had a lot of help from my my web designer. She's been incredibly helpful.
Well, let's just get right into this interview. From your website, learned that you've been practicing since the 70s. So I think you're probably the most experienced doctor that I've met to date who's performing RFA. One of the main questions I have for you going into this interview is just how common was it in the early years of your practice to see thyroid nodules versus now? Are you seeing them more commonly now than you had in the past?
Well, I think I probably am seeing more now than in the early 70s because being long in the tooth as I am, back in the day, before ultrasound and imaging was so widely available, really, unless somebody had a palpable nodule, they never really came to somebody's medical attention. So usually by the time in a primary care setting, someone might be noted to have a thyroid nodule, particularly since they're more common in women. Gynecologists in my area were actually pretty good about feeling necks, and they'd say, hey, what do you think about this? And they'd send people to me. But again, ultrasound was not as sophisticated, not as sensitive as it is nowadays. Actually, even CT imaging and such was kind of rare back then, and MRI hadn't even been invented then. You know, frequently we're seeing more thyroid nodules now because they just get discovered. A lot of times they're incidental. Somebody gets in a car accident and they wind up in the emergency room. They get a CT scan to see if they broke something and you know your neck is fine, but oh, by the way, you've got this thyroid nodule. So we see a lot of them that come to me that way. Certainly the larger symptomatic ones, people would come in because of the symptoms, but the smaller ones really were less commonly found, but I don't think they're occurring more often. I think it's just that they're getting picked up as incidental findings more now. If somebody was having pressure or pain or trouble swallowing, or they started getting hoarse and you start investigating the cause of their symptoms, I think the incidence of finding symptomatic ones is probably about the same. Certainly finding little ones, and of course over time, some of the little ones become big ones.
That's what happened to me. It's interesting how now that we have more nodules being discovered with newer technology, there doesn't seem to be more understanding on the patient side about
how most nodules are really not a problem. I don't know if you encounter this in your practice, but what we encounter in our Facebook group often is that once patients find these nodules incidentally on imaging, they are terrified that they have thyroid cancer and that they're going to die. And they don't understand that these are usually very benign and harmless growths, and that even thyroid cancer is not something to really be compared to a lot of other cancers that we're more used to seeing in family members, that are struggling tremendously. Do you see that in your practice where patients are just very scared when they have this diagnosis?
Oh, certainly. Well, the first thing anybody thinks if you have a lump, obviously, is, oh my goodness, I've got cancer. And you're absolutely right. The risk of cancer is not zero. The overwhelming majority of these are benign. And the small percentage, and there are different studies that go into what the actual percentages are, but the number is small. We're somewhere between 3 and 5% of these incidentally discovered things turn out to be cancer. The bulk of them are completely benign, and most of them never get to a point they require intervention. And there's even a school of thought that some of the smaller cancers might not require intervention. That's a little more controversial. The opinions are out there, and there are studies out there that some of the smaller cancers might not even need any sort of intervention at all. That's not mainstream yet, though.
Yeah, but I really like that line of thinking because it's a very much more holistic line of thinking where we're going to consider the outcome of the surgery might be less beneficial than the cancer being in the body and not causing any problems. So, of course, I'm not a doctor and I don't have all the understanding of how thyroid cancers work, but just for my layperson understanding, that is something that I think resonates with a lot of patients.
Right. No, I think that's true. They're not all slow growing, and occasionally, again, I tend to be the person that winds up seeing the more advanced or some of the less common ones. Even when they are cancer, the common cancers, the typical papillary cancers and follicular variant papillary cancers are generally slow growing and not. Even when they do need treatment, the treatment's frequently not urgent. And again, over the last 20 years or so, the treatments have become a little bit less aggressive and the outcomes are just as good, if not better. Every few years, the guidelines that we use to sort of see how aggressive do we really need to be change a little bit. And in general, they've gotten less aggressive, less extensive surgery and less use of radioactive iodine. Occasionally, you do find a bad actor. Fortunately, they're rare. When they need aggressive treatment, we give them aggressive treatment, try and individualize the treatment for what the problem actually is and try and get the best possible outcome.
What do you think about the number of thyroid surgeries every year in the U.S.? I believe it's something like 250,000 a year. Do you think that there's been an upward trend? Do you think that has something to do with the increase in imaging capabilities?
I think it probably does have some relation to increase in imaging capabilities. There's some regional variations in the country too. In some parts of the country, incidence of surgery is a little higher than other parts of the country, but I think in general there is sort of a slow uptick. It's also your bias, and my bias in general, not just for thyroid, but for everything. You're looking at a condition, and I'd say, what's the least aggressive and least harmful thing that you could do for this person that's going to get them a good outcome? Most of the thyroidologists who deal with these kinds of problems are typically thinking less is better. The surgeons, of course, if you go to a surgeon, that's what they do. If your car is making funny noise and you take it to a muffler shop, chances are they may try to sell you a muffler. A lot of it is driven by, who's actually getting involved with the patient. But again, back to your point, I think there is more surgery, and I think a lot of it is probably not optimal for the patient, and frequently other options might be a better way to deal with the problem.
Well, and that leads me right into asking you about how did you discover thyroid RFA and what led you to adopt it, because it is a less invasive option for patients to treat their nodules.
Of course, the technique, it's new in the United States, and it's only been approved by the FDA. I think we're into the second year of FDA approval now, but I've been aware of it for some time, and the technique originated actually in Asia by the South Koreans. Anyone who's kept up with the endocrine literature or goes to thyroid association meetings and that sort of thing, we've all been aware of its existence for a while, and there have been some people in Europe, particularly Italy, were early adopters, RFA and also a laser technique. That the laser has not caught on so much here in the U.S., but these alternatives, we've been aware of them for some time just because of following the literature and trying to stay current. When it became approved and the equipment was approved for use, I've been sort of looking forward to being able to offer this as another option for dealing with the problem. Jumped right on it as soon as it became available.
Amazing. Well, how did you get trained in the procedure? Did you go to a training seminar? Or?
Yeah, there's nothing in the United States right now as far as any formal training seminars. A couple of sort of semi-formal things have popped up over the last year. They've been a little bit slowed down with the COVID pandemic. In my case, once the approval came, one of the manufacturers of the equipment helped me out because I happened to deal with him for my ultrasound equipment anyway. Said, well, there were a couple of options. You could go to South Korea, or there was a place in Rio de Janeiro in Brazil where it's been approved for a little longer than the States. And there was an experienced surgeon there who's been doing the technique for some time, and he was offering a training session. So Brazil being a shorter air flight, I went to Brazil and went down there and took the course and met with everybody and some of the people I knew, again, through professional meetings, because a lot of the South American and Asian, for that matter, folks do come to the meetings in the U.S., and we sometimes travel overseas for some of our meetings anyway. So I went down there with a few colleagues, learned how to do it, practiced on some people under supervision, of course, and became comfortable with the technique and started doing it.
Were you by chance with Dr. Hands at that training, Dr. Kathleen?
Yes, so Dr. Hands and I are long friends. I don't even remember how long we've been friends, way over 20 years. Yeah, but we did attend the same session, yes.
Yeah, I remember Dr. Hands talking about going to Rio, and so I just was curious if that was the same training that you were at.
Yes, that was the same one, yes.
And then when were you able to start offering it in your practice?
At the time, I was in a transition in my physical office space, and I didn't have the physical space to actually do it. So Dr. Hands actually got a little head start on me. Mm-hmm. She was able to start doing it in Texas several months before. It took me about an extra 7-8 months before I was situated. I was in the process of building out permanent space and getting a procedure room set up and everything. So I've been doing it, over a year anyway.
And how many patients do you think you've treated with RFA?
Around 20 right now. I think there was a backlog of people, probably through your website largely, who were sort of waiting for this to happen. Of course, again, as you know, most commercial insurances and Medicare have not started reimbursing for this, at least to my knowledge, unless something's changed in the last month. Unfortunately, there's a significant out-of-pocket cost for this for a lot of people. I think the people who were sort of chomping at the bit to get it done largely found somebody to get it done. And now we still do get calls for it and everything, but I think the initial surge has sort of passed. I think people are probably a little bit on the sidelines now, kind of waiting to see how long it takes for the commercial insurers to pick it up and see if they can just have it done as an alternative to surgery that won't involve a significant cost.
That's a hot topic of discussion in our group. We have some people say, I just really want this to be covered by my insurance because it's a matter of principle, believing that this is better for me. I shouldn't have to pay out of pocket for it. And I completely can see that perspective. And then there's also people who are in a situation where they need this done and they don't care that it's not covered. They're just willing to pay to keep their thyroid intact. So there's a large group of people who fall into that category. Ideally they would have it covered, but because they can't, they fall into that category. And then there are a lot waiting. They're not in an emergency situation yet where they just absolutely need this treatment like tomorrow, but that's what they're hoping for when they reach the point of needing to be treated. And so they're just going to kind of sit back and wait and see when insurance companies will pick up. And I believe that we're on the right track. I've seen a lot of patients be successful with their insurance companies. Some of them have to appeal a few times, and some of them are not successful, but several have been successful, and one of them includes me.
No, I think it will evolve that way. It just takes time. One would think if the people who are making the decisions in the insurance industry were using logic, which is a stretch for many of these folks, but they would look at the procedure and they'd say, okay, the cost, and again, the costs vary for the radiofrequency ablation, and sometimes it takes more than one treatment, but for larger nodules, nodules, and even considering all of that, just looking at dollars and cents, not even considering preservation of the thyroid, day treatment, lack of general anesthesia, all the other things, lower risk of complications, all the benefits. Still would say the insurance company is always looking at the money because that's their job. They would say, well, it's still a lot less expensive than having a lobectomy or your whole thyroid removed. One would think they'd be highly motivated to go for the lower cost option. It just takes them a while to figure it out. Yeah, but I think it will happen. It's clearly evolving that way. It just takes time.
Yeah, we don't really understand why you would take someone who could have one procedure, maybe two, and not need a lifetime of medication, and to decline them that opportunity and say, no, we want you to have a $30,000 surgery, and then we're going to pay for you to have medication for the remaining years of your life, which could be, who knows how long. So that doesn't really make a lot of sense, as you said, logically, for them to deny that. So hopefully we're on the right track. It sounds like we are. And I don't know if you've seen this recent buzz about the laser having a code assigned to it, a CPT code. Many of the patients in our group are like, well, what about RFA? We need to get that a billing code because it's already been FDA cleared and in use for the last 2 years.
Well, I know it's being worked on, but again, those things take time too. There will be a code at some point, and then when there's a code, then there will be a push for reimbursement and for have insurance coverages. It's just a lot of inertia in the industry. Unfortunately, it takes longer than it should.
Well, let's talk about your office setup, because you were mentioning you had to build out your office space a little bit. What is your setup like? Do you have like a procedure room in your clinic?
Yes, I have a procedure room. I set it up with an eye towards being able to do RFA when and if it got approved, but I set it up basically to do the procedures of when someone comes in with a thyroid nodule. The ultrasound machine is there. We've got a nice, comfortable, adjustable chair, that one of these infinitely adjustable surgical things that you can pretty much put somebody in whatever position they need to be in. And we use it for diagnostic ultrasounds and ultrasound-guided needle biopsies. I also do peripherally related things, percutaneous ethanol. Sometimes everybody doesn't need radiofrequency ablation. Some nodules are cystic, and sometimes just aspirating the fluid out of the nodule, and if it reaccumulates, putting a little bit of ethanol in to create some scar tissue is a much smaller procedure, which actually is covered by insurance. So we do procedures like that. So we've got a nice, comfortable room where we can move things around, and my nurse is very comfortable. She has a lot of operating room experience. We can set up a sterile field and get all gowned up and do everything we need to do, and nobody feels crowded. We have a pleasant environment to work in, and it works smoothly.
That's great. I think with my experience, mine was done in a hospital because that's where my doctor was located, but I think for patients that can get this done in a clinic setting where they go into an office and they have it done and then they leave and go about their day, such a different experience than the stress of going into a surgery and knowing you're going to be put under all that goes along with that, the fasting. It's just a lot. And so to know that you can have RFA done in an office, almost like a dental procedure, is just tremendous. Patients love the non-invasive aspect of it in all aspects of their life. So that's really cool that you've got that set up there and that you actually tailored it to having this procedure available in your office.
Well, the timing was very fortuitous. It just worked out since I was relocating at the time anyway, and we just had the chance to just sit down with the architect and just say, let's just do this. So it works. So we built it specifically for that, and it has worked out very well. I've been quite pleased with that, and people certainly do seem to appreciate not having to hang around in a hospital setting and all of that. And we get people in and we get it done, have somebody, they're awake through the whole thing. I actually like the fact that they don't have to be asleep. I can talk with them. They can tell me if they need a little more Novocaine or whatever. And the fact that they can talk to me tells me that I'm not harming their voice or anything, which if the person's asleep, you can't tell till you wake them up. I generally have people take a mild sedative before just to kind of relieve any anxiety, but they're fully awake, and we're chatting about things. I can ask them, how are you feeling? How's it going? They can ask me, how much longer? That sort of thing.
Generally, how long do your procedures last?
The actual amount of ablation that's done is seldom over even 10 minutes, actually. But the whole procedure, usually 40 minutes, 45 minutes, occasionally an hour. I mean, a lot of time is spent just getting the probe position where you want to actually do the ablation. So there's a lot of movement and positioning ultrasound guidance going on, but from start to finish, we're usually in and out by the time we get everybody cleaned up and prepped and done, about 2 hours.
And do you do these on a regular basis in your clinic? What's your patient load like?
We have one designated day, so typically Friday is our RFA day. If we have a patient scheduled for the day, that's it for that morning. Sometimes we have the capability to do a couple a day. If we won't schedule other patients, usually we'll just devote a session just to taking care of that procedure that day. So we schedule them in advance and make sure no distractions or anything.
And currently, are you just treating benign nodules, or have you stepped over into the realm of thyroid cancers with RFA yet?
So far, I've just done benign ones. I'm looking at that, and I have talked with a colleague who's a friend of mine who just recently left Johns Hopkins and relocated down in Florida. I don't know if he's actually done any yet. I know he was kind of moving that way. I'm thinking about it, but I have not taken that leap yet.
Now, I understand that's a whole different ball game and that there's different things you have to do as far as the method.
Yes, so it's a little more involved in a research setting. I mean, certainly I'd be willing to participate in that, and that's actually where our discussions have been, sort of looking at getting together a research study to see what sort of results we might get. There's been very little work of that in the world. I mean, there's couple of Chinese endocrinologists have done some studies, and I've reviewed their work. They've had what I consider mixed results. I mean, they've actually had the opportunity to go back. They were doing it on people who then went ahead and had surgery afterwards, so you could sort of see the results and did we get all the cancer and that sort of thing. It's a little bit of a mixed bag, so I think, at least in my opinion, I'm not sure that that's ready for prime time yet. But it's very interesting, and I think it might turn into a routine treatment option.
It's definitely something we see a lot more discussion on in the group than we used to, now that there are a few doctors out there who do it. And also patients can go overseas and have it done in certain countries. So we're seeing a lot of people asking, is it here yet? Is it here yet? And that's always asked whenever I announce in the group I'm going to be interviewing a physician. They're always wanting to know, do they do cancer cases? And you mentioned the possibility of putting together a research study. Is that something you're very seriously considering?
Yes, I am actually. I'm looking at that, just discussing it with a couple of other doctors who also do RFA.
Excellent. Well, if you need patients, we've got them.
Well, that's good to know. Now, that actually is good to know. See, the issue there would be, I think, once insurance does start to pay for the benign ones. Again, if there isn't official FDA approval for treatment of cancer, insurance won't cover it. So it's still going to be the sort of thing you'd need to have people sort of volunteer to participate in the study, and what's your control group going to be, and how are you going to follow them for recurrence, and all of which is manageable, but it just is complicated to set up such a thing, and who pays for it and how long do you follow them and that sort of thing. But we are talking about it.
Well, that's exciting. Well, please let me know if you decide to go down that road. I have one more question for you. I've just recently become aware that RFA is now available in my home state. I'm in Alabama. I was speaking with a doctor at the University of Alabama, Birmingham, who's going to be doing this program, and she was talking about some of her patients are going to be having a combination of RFA and surgery, where one side has to be removed, and then the other side, to preserve it, they're going to treat nodules with RFA. Okay. And I have not heard any doctor mention that to date. So I was just curious, has that been something that you've done in your practice, or you've encountered in your professional experience with other physicians?
I have not encountered that personally yet. Couldn't really give you other than a general comment. I think perhaps if one side of the thyroid had an extremely large nodule, or it wasn't readily accessible or amenable to a single RFA ablation, or even some of these things can be very large, as I'm sure some of your site members have noticed. I mean, I do see people sometimes have 4 or 5 centimeter nodules. They sometimes, that was you, okay. They can extend down under the collarbone, down into the upper chest. Some of these things are really huge. Certainly something like that might require multiple RFA approaches, and you can sort of work at them from the top down, and then the lower portions will sort of work their way up. But you get in, again, it's multiple procedures, and there's always the cost issue, and how many times do you want to go through it? So even though you say it's probably not as bad, or no worse at least than some dental procedures, still, how many times do you want to do those either? I would imagine a situation like that might be a very large nodule that might just be best dealt with surgically and then try to preserve thyroid function. If they're smaller ones, you could ablate them with the RFA probe on the other side. But I'm sort of guessing that might be the situation. I haven't run into one of those yet, but I mean, it's certainly not an irrational path to take if that seemed to be the case.
I think that there are a lot of patients out there who would love to go that route if they absolutely have to have surgery. Patients that want to keep that other side that they're not having removed from having any issues from those nodules. Thank you for doing this with me today.
Oh, you're very welcome, Jennifer, and thank you for inviting me to do it. I hope we get the word out there. I'm a big adherent of it. I think it has a huge future. Technology will only get better over time. I think it'll be routine practice over the next several years.
Thank you so much for watching. You can help others tremendously by sharing this content. Never forget to educate yourself and be your own health advocate. Now, watch this next video right here.